Hello, everyone, and welcome. We are PD Connect. I am Lisa.
And I'm Steph. Thank you for joining us today. We teach exercise and education for people with Parkinson's, and you're here at our speaker series. Welcome, Dr. Bath.
Yes.
Thank you for being here.
Today, we are going to be talking about freezing of gait with Dr. Jessica Bath, and I am going to just read a short bio. I'll let you do that, Steph. So the speaker earned a PhD in Rehabilitation Sciences, Neuroscience, studying postural instability in people with Parkinson's disease. She will talk about her research into the underlying pathophysiology of movement disorders and the role of physical therapy interventions that can improve motor function and quality of life. Let's be clear, Dr. Bath is a physical therapist, a fabulous one at UCSF. This lecture is appropriate for anyone with balance and gait concerns or anyone wanting to stay ahead and ward off freezing of gait. She's also an adjunct professor in the Department of Neurological Surgery and the Department of Physical Therapy and Rehabilitation Sciences. Welcome, Dr. Bath.
Thank you for being here.
Hi, everyone. Thanks for having me. I'm going to go ahead and share my slides really fast. All right. Can everyone see them okay, Lisa?
Yes.
Okay. And it sounds like we're hour max, and I'll make sure to stop a little bit ahead of time for questions. Is that the plan?
We can go as long as you can go, but yes. We have at least an hour. Let's say, put it that way.
Okay, perfect. All right. Well, thank you, Lisa and PD Connect for having me. I'm excited to be here and talk about hopefully some topics that are very relevant to each of you, unfortunately, but that are helpful in the information that I hope to convey, as well as, answer any questions or things that you might be thinking about this. So the talk that I'm going to be giving is called Freezing of Gait and Parkinson's Disease. And just to kind of talk about what to expect. So I'm going to go into some background on freezing of gait and how we sort of characterize it from a clinical and research perspective. Define some terms related to these symptoms, because you might hear things thrown around: freezing of gait, fascination, start hesitation, and sort of those all are related symptoms, but not quite synonymous. And then, as Lisa said, go into physical therapy really as sort of the primary intervention I'll discuss today for improving freezing, and briefly talk about some other sort of topics as it relates to research that myself and others are doing as it relates to freezing, as well as sort of some other therapies. So just to kind of give an overview of the talk, I think sometimes these talks are hard because there's some bad, there's some good, and then kind of a what's next. So to give everyone sort of a holistic view of this symptom, I try to sort of go through all of it, but do know hopefully that there's parts to kind of get through and then parts to look forward to that give me hope, certainly as it relates to freezing. I don't have any disclosures to report. I do help out with the ongoing research study, which I'll talk about at the end. With Skip Labs, and just to note that none of these products that I'm going to talk about are endorsed. This presentation is for informational use only, not medical advice. So please talk to your providers for anything discussed here today. So just a brief thing about me. So, sort of what got me into this research field and things like this. So my grandfather actually had Parkinson's disease. So this, ironically enough, he was actually diagnosed while he was in physical therapy school. So it was this weird sort of parallel process of learning about physical therapy intervention for Parkinson's disease and also watching my grandfather experience it and his symptoms and his journey with care. So I would say it was sort of a unfortunate life experience that I got firsthand that actually proved to be really, I would say, beneficial in, the way that I approached kind of researching this and treating this condition still today. I also ran college track and actually played soccer as well in college. And so I think with Parkinson's, I find that there's this competitive nature. I don't think I've ever met a patient with Parkinson's that wasn't very competitive. And I think I really resonate with that and bring that to both research as well as when I'm treating patients with this condition. In PT school, I started getting involved in research and actually participated in an adaptive CrossFit group And so I think sometimes as physical therapists, not Lisa and her team at PD Connect are awesome, but sometimes some physical therapists are worried about, making people with Parkinson's work and, really putting them through their paces and things like that, where we see the benefit of physical therapy. And so I think as a student doing classes like this really made me, not hesitant to, make these patients work and really, just not be afraid of challenging people. And so I think I took all of that, and now I actually just finished my PhD this summer, and so now I'm officially an assistant professor where I do thank you, where I do continued research into postural instability in the Department of Neurological Surgery at UCSF, as well as teach PT students, and then also see patients in clinic, primarily with Parkinson's disease in the new Bayfront clinic that just opened up at UCSF. So I'll move forward. So, just to talk a little bit about some of these terms as promised, as well as where freezing of gait comes from. So Parkinson's disease, as I'm sure many of us know on the call, is at least initially produced by, basal ganglia degeneration. And this is what gives it the term movement disorder, because this degeneration oftentimes manifests as motor symptoms. And so these classical symptoms that we think of are tremor, bradykinesia, which is a slowing of movement, rigidity or stiffness in our muscles and joints, and then postural instability. And in particular, my talk today is going to talk about postural instability as sort of an umbrella that freezing of gait sits into. So for postural instability, the way that I talk about this term is, we have this sort of underlying foundation, so to speak, of things when we're walking or we're balancing. And it sort of basically refers to our ability to maintain the body's position in space, ensuring stability prior to and during activity. And it really is actually, it relates to where we're at as it relates to gravity, because ideally what we want to do is keep sort of our body's mass in between our legs to give us support and maintain our balance to prevent falling. And what happens is if we start to lose our ability to maintain sort of our body and our trunk's position in between our legs, when we're doing things like walking or balancing, we really are then unable to produce movement that's coordinated, that's quick, that's purposeful, things like that. As an example of this, if, I think maybe some of us are in the Bay Area, a lot of us, but if you were on a BART train or a bus, and the bus, you were standing up, you were holding on to the thing that, the strap, and you're holding on, and then all of a sudden the bus stops at a red light and slams on its brakes. What we would need to do to keep our balance, to keep our body's trunk in between our legs, is to generally probably take a step, all of a sudden, a quick, forceful step, and that would keep our balance to prevent us from falling. But oftentimes what we see with Parkinson's is if we go to take that step, either that step is not quite big enough to prevent us from falling, or that step is too far, too slow, where we're not doing it in time to catch our balance, to keep our trunk between our legs, or we don't step at all and then we fall. And so that's just one example of sort of this relationship between walking, between keeping our balance, and sort of how postural control is underlying all of that. So there's a lot of terms that people may have heard of as it relates to sort of postural instability or postural control. And some of these are freezing of gait, start hesitation, or festination, which are all under sort of postural control and instability as it relates to walking. For instance, so the way that I think about this freezing, we call this an involuntary. So obviously nobody wants to stop suddenly walking when they have the intention to walk, but it's an involuntary sort of stopping of walking. It fluctuates and it's transient, meaning sometimes we have it, sometimes we don't. Start hesitation is a similar sort of symptom where we have difficulty starting to walk despite wanting to walk and have the intention to walk. Festination is sort of another similar symptom that runs in this category, and we would consider that sort of these rapid small steps to keep ourselves balanced. And really it's because we start to lean our trunk forward to try to keep, again, our body, our center of mass in between our legs, as we're unable to step. So our feet are staying still and we're going to start leaning forward to try to get it easier, to make it easier to get our foot off the ground. Okay. And we can also see these balance related postural instability symptoms too in various ways. So static balance would be if I'm standing still, maybe I'm cooking, maybe I'm, trying to just, it's a balance game and I'm trying to stay as still as possible without moving. What you might notice is that that's really difficult. You might kind of sway. You might notice if you close your eyes, it gets really hard and you really start to sway. Okay, that's all related to static balance. Reactive balance is that example I gave before where you're on a minibus or BART and it stops suddenly and you take a step to prevent your loss of balance or a fall. And then anticipatory balance is really what we would consider sort of the things that we do as it relates to where our trunk is in space and our feet as we prepare to do something. So it might be you're walking across a parking lot and you see sort of that cement block that's, at the end of the parking spot. So what you're doing as you approach that piece of cement is you're going to adjust your body and adjust your step so that you can clear that obstacle. And you actually do that pretty far ahead of time. You're not doing it right when you get to that object. You're preparing to step over that object ahead of time. So anyways, these are all examples of sort of manifestations of what we consider postural instability in Parkinson's disease, of which freezing of gait falls into. So typically as researchers and clinicians, when we try to treat this symptom or we study it, we're often sort of looking at freezing of gait as an umbrella of these symptoms together or that run together as it relates, we call them postural instability, okay? All right. So just to kind of where we might see postural instability as a symptom in Parkinson's disease is typically later on. So you can see the box here. If this is sort of the trajectory of Parkinson's disease from maybe before diagnosis through late stage Parkinson's disease, and then the increasing kind of symptom burden that we would expect to see over time. Generally, postural instability tends to be at sort of the later stage of the disease. Not always. There's certainly subtypes of Parkinson's where this is not true. But generally speaking, it's something that we see in the emergence sort of with a longer symptom duration. I also want to make the note too that I think sometimes patients have a question on, is this common? And the answer is typically yes. So there's a paper that came out saying that 34%, so over 1/3 of people that were diagnosed with Parkinson's demonstrated symptoms of postural instability, including freezing, within 2 years of diagnosis. 10 years later, 71% of this study sample exhibited those symptoms. And then at 15-year follow-up, 92% of the sample exhibited these symptoms. So it is sort of, I would say, not uncommon at any point of the disease and sort of at these varying time points. Unfortunately, sort of that is generally an expected symptom that we would think would emerge over time. Okay, some other things to just get out of the way really fast, and I'm going to put this up because this etiology or sort of, why we think freezing happens. I put up the question mark because at the end of the day, everything I'm about to tell you is what we know so far. This is not tie it up with a bow. We feel great about this, and what I'm presenting to you is facts because truthfully, this often is anecdotal and it's things that sort of we're continuing to refine over time. However, I do want to note that this person, this researcher in the corner here, has produced some very sort of seminal works in sort of why we think freezing occurs. And so this is sort of where my talk focuses on today, but I do want to preface this by saying, none of these are ground truths. So why we think freezing of gait happens is sort of a decrease in the automaticity of gait. And what does that mean? We have specialized centers in our brain that control a lot of the functions of movement, of human movement. So for instance, when I go to walk, I do not have Parkinson's. When I walk, I actually kind of have this sort of rhythmic, my arms swing opposite my foot going up. I'm not thinking about every piece of that movement. I'm not thinking about my arms need to go here. They need to be opposite what my legs are doing. My head needs to look up. I'm not thinking about any of that. And so what happens with Parkinson's disease is there's a change where we start to lose that automaticity, where we're suddenly losing, maybe our legs are doing something opposite than our arms are doing, et cetera, et cetera. That's the automaticity part. The other thing is we start to see difficulty with communication between brain regions for switching between motor programs. And this, you have to hear me out a little bit, because those of us that study neuroscience, is a very common sort of assumption, but if you don't live in this world all the time, basically what it means is we think that you have motor programs that the brain produces, this set of instructions, if you will, that comes from the brain, that's refined in the brain, and goes to your legs, your arms, your trunk, and says, do this thing until you're told otherwise. Okay. And so those motor programs are basically this sign, sealed, delivered note to the rest of our body saying, do this thing, such as walking. So if I'm walking through a parking lot, nobody is around, the sun is out, no cars, no obstacles, and I'm just walking, that motor program is likely telling me, walk, just walk. Okay. Now, for instance, let's say a car comes around the corner. Okay. I'm going to have a motor program now that needs to tell my body, my brain, stop that motor program, and instead make a motor program where you aren't going to walk anymore and you turn your head to look at the car. Okay, so now I have a different motor program going. Okay, and what happens with Parkinson's disease is we have difficulty sort of as that car comes around the corner and I'm walking to turn off that motor program that says keep walking and to start or initiate that motor program that says stop walking and look at the car. Okay, so because of that, it's this difficulty all of a sudden with switching between these motor programs effectively and quickly, okay? The other thing to note is we often see a decreased sort of perception of a response to stimuli. So for example, in Parkinson's disease, it's well documented that our feet, for instance, become a lot less sensitive to feeling the ground, to feeling sensation from the feet. And the feet give us a lot of information about where we are in space and what the kind of environment that we're in and things like that. So now all of a sudden, we sort of have a change in our ability to know where we are in space and things like that. Beyond that, we also have what's called central fatigue, which we would see where it's basically kind of this persistent nervous system driven fatigue. So I went to the grocery store and I was on my feet for 5 minutes, and now I'm going to go home and rest because I'm tired. This is actually a different sort of fatigue that's thought to be associated with sort of prolonged and increased cognitive processing, where it's the nervous system is actually sort of overstimulated or overexerted, and it tends to last for multiple days in this longer period of time than just I walked 3 blocks and I'm tired afterwards. And so really what happens with that central fatigue and taking more cognitive processing, our brain working a lot more all the time, is we can tend to overload our system really easily, or our threshold for feeling overwhelmed goes down. Okay, then the last thing to say, and this is I would say a very hot sort of topic in terms of all of this, is some of our freezing of gait a byproduct of treatment? Okay, because oftentimes, currently in the field, levodopa, which is that medication that oftentimes people are on, carbidopa levodopa, which is a dopamine replacement medication, we think it benefits freezing. So there's lots of studies showing that people that are off medication have more freezing episodes than people that are on medication. And that's pretty established in the literature. However, interestingly enough, there was actually this kind of historical paper that was published where it said freezing of gait was not really mentioned in the classic literature until after like the 1970s, of which was about when we started managing Parkinson's with chronic levodopa use. And so it might just be that nobody was thinking about this before then or characterizing it before then. But certainly there have been some papers in the literature suggesting is freezing, and because you see freezing longer over time, is there some relation to sort of prolonged effects of levodopa? Okay. And I'm going to leave that there. We can address it in the questions, but I would say that's a very kind of, well, there's one other time I'll address it in the talk if people actually have questions. And the other thing to note, I always joke, I put this very complicated diagram up, and I joke when I teach physical therapy students that they have to memorize it by the end of the term. But basically, the idea of this is why things are so hard to study is because we don't have one brain region that's just in control of movement. We don't have just one thing that says to walk, this thing needs to be activated. Okay, so really, the product of walking, of balance, of movement, of postural control, and the circuits that we think are sort of affected in Parkinson's disease and also affecting or causing freezing are multiple regions. So in this black box, you see the basal ganglia, but hopefully you can appreciate without needing to worry about anything else, how interconnected it is to all these other parts of your brain on the top for the cortex, as well as in the midbrain here. The other thing to note, and again, you don't need to worry about the abbreviations, is just not all of those connections rely on dopamine as a neurotransmitter. So what that means is if we're using levodopa, which is exogenous dopamine, to treat this condition, to treat freezing, we might be finding some of these places in the circuit which are being benefited by this therapy, but not all of them. And why that gets tricky is because, let's say, for instance, somebody's going to start to walk. Starting to walk is one of those things we would call an anticipatory activity. So I need to decide to put my body in a position to be able to walk before I start to walk, if that makes sense, okay? And really what we're doing during that is we're taking a weight shift and we're taking a step. So I have to weight shift my body to one side to unload that foot that wants to take the step, okay? But what if the circuits or the brain regions involved in the weight shift are able to be treated, but the step isn't? So now all of a sudden I have a really big weight shift or a very fast weight shift without a step. Or perhaps it's the opposite. Perhaps I made the step really good and really big and really fast because of the levodopa. But now my weight shift is no longer there or no longer is scaled with my step. So now all of a sudden, maybe I'm not really weight shifting, but I'm taking a step. We probably wouldn't consider that to be a win as it relates to sort of benefiting your symptoms, because there would be a missing part, which actually might even be worsened by sort of what we're introducing. Hopefully that makes sense. The take home here is basically just to know that this is very complex to study because there's a lot of areas that sort of are affected in human movement and walking and balance, and also that not all of them are going to be affected by dopamine or levodopa, okay? Okay, hopefully I haven't lost people. I apologize. This is the world I live in, and it's complex, and I certainly can take questions at the end. So treating sort of how we treat postural instability and freezing of gait in 2024 is we sort of think of, or myself in the field, some of these things are pretty well treated with physical therapy, with exercise, maybe a device like a wearable bracelet, an anklet, cueing, sorts of those kinds of things. And then there's some other symptoms that generally we would better expect to be treated by sort of medical management. So whether that is levodopa medication, deep brain stimulation, or Botox. And I would say right now where the literature is at, typically these bottom three. So dyskinesia, tremor, and rigidity, we often let sort of medical management, neurologists, neurosurgeons handle that. And then typically I would say we get better outcomes with physical therapy and exercise for kind of these top two. Now, maybe some neurologists and neurosurgeons wouldn't like me saying that, but I think anecdotally and also what the research shows, this is often sort of where kind of we all need each other to effectively manage these symptoms. However, what are the challenges as it relates to treating this symptom? So with physical therapy and exercise, or even sensory tricks, which we'll get into and things like that, really what we're up against is we need to create lasting benefit and carryover, because really our interventions currently are tend to be only as good as we keep them up, which is great in practice, but sometimes we're not able to always do that, or sometimes we're humans and we have other things going on in our lives and things like that. And so there's this issue of creating that benefit. The other thing too is there's virtually no evidence on the combination of physical therapy and deep brain stimulation to guide us in things like, is it more effective to sort of get DBS and physical therapy together at this time versus later versus earlier? How much, what should we be doing in physical therapy? Things like that. I'll also add too that for levodopa, just like I was saying, this was the other piece. Often with levodopa, we see it improve some aspects of this, but not others. And so for the instance of postural control, such as freezing, what a lot of studies have shown us is that levodopa can actually worsen symptoms. And that goes back to probably the point I was making before, where it's not these synapses or the neurotransmitter is not just dopamine that it relies on. However, I should point out that levodopa is not something that we would just be taking away from people if we're trying to treat. Certainly, this is the difference for a lot of people of getting out of bed in the morning, being able to move around, function, things like that. And so oftentimes what we're trying to do now is, okay, how do we keep somebody using levodopa for all those other things they need? Tremor control or movement in general. But can we use something else to potentially minimize or mitigate the effects that levodopa has on postural control? Okay. And this is sort of what oftentimes where DBS comes in. Because like I said here in the second bullet point, oftentimes with a lot of these, whether it's static, you balancing and just not doing anything, you balancing quietly, or it might be a reactive step for balance. Oftentimes levodopa can worsen sort of those responses, but then DBS improves them. So we sort of get this like net zero effect, where somebody can still be on levodopa for all the other benefits of these symptoms it has, but we can also sort of improve the effects that it might have on postural control in a negative way, okay? The other thing I do want to note about deep brain stimulation is oftentimes if people are getting deep brain stimulation for sort of all the classical signs of Parkinson's, so maybe tremor, for instance, oftentimes what happens is the settings of DBS that somebody needs to be on long-term for sort of gait and balance and postural control, freezing, for instance, they need to be treated at much lower frequencies, sort of the opposite range of where people sit and where they're optimized for things like tremor control, things like that. Okay. And so what oftentimes happens is we have sort of this delta that exists where, maybe freezing, we want you to be at these low settings, but tremor control, we want you at these really high settings. And so your neurologist is sort of, faced with that conundrum a little bit of treatment as a result with deep brain stimulation. So there's kind of this puzzle that all brings us to say, what do we do about it? And some of that I'll talk about the research, and some of it is why I love to be a physical therapist that gets to study this topic, because we have a lot of good support for physical therapy in a way that we don't get lost in what is medication doing, these opposite parameters for DBS, things like that. We get to just work and have fun. So kind of the good, of course, I'm a physical therapist. I feel like I have to say the good here because I believe in it, but there is some other good that I threw into that's not just physical therapy. So just to kind of make a note first before we go on. So there's a lot of evidence to suggest that physical therapy, exercise, things like that actually have a disease modification piece to it. And we really would expect to see sort of that disease modification component to it, the earlier or sort of the biggest effect, the earliest that we intervene, okay? And what that basically means is sort of there's this gold line here that's going as sort of our symptom duration increases, we would expect to see sort of increased effects of the disease process, whether that's our motor symptoms, our falling, it might actually be some autonomic change such as hypotension, things like that, okay? But then we see this dashed line here where our disease modification course, so again, starting as early as possible ideally, but even if you haven't, with the effects of like exercise and physical therapy on sort of this flattened curve where we get to hopefully stretch out sort of how long it takes us for those symptoms to emerge, as well as when they do emerge, can we minimize sort of the effects that they're having on somebody's daily life, okay? One other thing to note, kind of the idea of PT intervention, oftentimes we would use a dental model to explain this. This is sort of a new way of thinking, which is just like going to the dentist, a few times every year for check-ins. We oftentimes advocate for that for Parkinson's disease and other sort of neurological diagnoses, because it allows us sort of these time points to work on really intense, focused intervention on a specific sort of symptom or thing that you want to learn. Maybe it's learning how to get on and off the floor, or maybe it's, learning strategies to prevent freezing, things like that. That would be really all good uses for sort of this focused period of time of physical therapy. And it is important to note too that underlying this whole curve and physical therapy would be sort of continued adherence to a regular exercise program as well. Okay. So treating postural instability, and this is, I talk to physical therapy students a lot, and this is where we focus on effective interventions for whatever we're talking about, but especially with freezing, are specific to the impairments observed and the person's goals, of sufficient quantity and intensity, so we call this stimulus, to drive change. There's a lot of results or a lot of research talking about neuroplasticity, or how we get the brain to change. And we know that we need a lot of repetitions and we need high intensity to drive neuroplastic change in the brain. Okay, and that's been well documented for years now. So ideally, our interventions will be multifaceted. So what that means is we're going to hopefully have something that gets your heart going, your heart beating fast, improves your cardiorespiratory systems, as well as your muscles, okay, as well as, your muscular systems as it relates to the speed and the power that you're able to generate. And then we hope that they're multimodal, meaning that we want to treat more than one thing. So for instance, if you came to physical therapy, yes, we could work on freezing, but we would also want to look at, are you able to kind of initiate walking appropriately? Are you able to get that foot out when the muni bus stops when you need to? Things like that, okay? So we're going to try to kind of use our interventions to treat more than sort of one of these issues. And then again, we want to facilitate carryover or benefit following maybe an intervention ending, or as we go through sort of ebbs and flows in our treatment. So the way that I think about how we treat this condition, postural instability and really freezing of gait, are three different things, which hopefully make sense based off what I showed earlier. And that's one, improving the automaticity of our responses and our ability to switch between tasks. So if I'm walking across the parking lot, again, and I'm walking, and then a car turns, I'm able to quickly switch from that automatic or that, sort of normal walking to a stop and turning my head to make sure that, I can see the car coming and that I'm out of the way, okay? The other thing we want to think about are strategies for addressing and preventing breakdown from occurring. So maybe we still are freezing, but what are we going to do when we sense a freeze coming? And how do we prevent that freeze from happening in the first place? The other thing that it's always important, I think, as physical therapists or as people to remember, we need to be able to sort of have the functional capacity to do these things in general. So maybe I've gotten my brain trained where I've gotten really good at switching between these motor programs, but I don't have sufficient power or strength or stamina to actually do that thing that I need to do and that my brain is telling me to do. So in that way, it's sort of all encompassing, where there's things that I need to think about, both training my brain as well as sort of my body and the rest of me for being able to do those things that I need to do. Okay. So for methods used for improving the automaticity of responses, so again, how automatic it is, how much we have to spend on doing that thing, we often think about using a metronome or treadmill walking. And the reason why we do this is because the basal ganglia is a region of the brain. Its job is to often either start our movements, tell the rest of the body, this is what we're going to do it now, as well as scaling its properties. So again, deciding, am I going to do this really big or really small? Am I going to do this way or that way? All of those things the basal ganglia is thought to be a part of. So what we're doing with adding a metronome, which is that fixed beat, okay, or treadmill walking, is we're actually basically using an external basal ganglia. We're setting the cadence, the pace, the desire of what we're trying to do without the basal ganglia doing it, like a cheat almost, okay? So in that way, sometimes what we can do is add this piece outside of our brain. And then we actually, if we do that long enough, again, going back to the stimulus that we need to actually initiate neuroplasticity and change in the brain, we get that sort of external carryover that we've driven from that treadmill or that metronome to when we're using just regular walking without that. Okay, that's the goal there. Other ideas for treating this include sensory cues. So maybe you've been told before things like a laser, a mirror, having lines on the ground that are targets can oftentimes help, where we're actually able to sort of use, again, it's that idea of we're using something external outside of our brain to reprogram how we think about how long our step needs to be or where our arms need to go. Okay, because maybe because of our basal ganglia, we aren't able to perceive that ourselves. I'm not able to perceive that my arms are doing something different than my legs are. But if I'm looking at a mirror as I walk and I see my arms doing something that I don't know what they're doing, but my legs are not doing the same or mirroring that, that tells me, okay, I need to play around with that a little bit to figure out what that feels like in my body to coordinate those two things better. And oftentimes this is hard to do. You might, certainly this would be something that you could do in physical therapy. But that's the idea, okay? So we're really using sort of these inputs, kind of cheats, if you will, to circumvent whatever the basal ganglia is having a hard time doing and providing that in the form of maybe a sensation at our feet, from our eyes, from a metronome, things like that, okay? And then the next thing or other things we can do would be dual tasking. So dual tasking is if you've ever walked and counted. I'm sure Lisa probably has you do that in class a lot, but naming things that start with R's while you're, maybe turning and going through an obstacle course, that's all dual tasking. And that's really working on our ability to get better at allowing our brain to kind of be focusing on movement and able to also do other things. Because unfortunately, on a daily basis, there's a million things going on at any time. My phone might be buzzing in my pocket. My spouse is talking to me about something that maybe I'm not focused on or care about at the time. I'm looking at traffic and making sure, am I in the right position that I should be where I'm safe? Is there a curb nearby? Is that skateboarder too close? Things like that I'm just constantly having to perceive. And so oftentimes, getting better at this dual tasking allows us to more effectively keep our walking, our balance, our freezing okay while these other things are going on. Okay. And then we need lots of repetition, going back to that previous point of neuroplasticity and what actually needs to happen to drive change in the brain. We need lots of reps and we need high intensity. That'll be a theme, okay? So some intervention examples here, Nordic walking, so trekking poles. I use these a couple different ways, but one example, and a lot of PTs like to use these, is because we work on a lot of different things. So again, going off that example of how do we make our interventions treat more than one thing relating to freezing and postural instability? So this is getting at upright posture. The other thing too is it's really accentuating our arm swing, okay? Oftentimes is an issue in Parkinson's. I tend to find too with my patients that if we can figure out the arm swing, the feet are usually very good at following and getting in the space that they need to be in, okay? So I tend to figure out ways to make arm swing a lot better and more symmetrical and higher amplitude, and then we move on from there. Treadmill walking. This is often really great because we can get the benefits of sort of that external cue I was talking about, where the treadmill speed is fixed. So all I need to worry about is not the speed and the setting and the automatic nature of walking. I just need to make sure my feet are following along. So that tends to be a really nice intervention. The other thing too is maybe we put somebody in a harness for safety, and then we can start adding some obstacles onto the treadmill where we're working on things like dual tasking, reactive stepping, things like that tend to be difficult in Parkinson's disease. And then lastly, another example are these external cues. So the U-step walker, if anyone is familiar with that or has one, it actually comes with a laser attachment. Metronomes, like I said, an easy Google search of metronome, Google, and it comes up. You can set how many beats per minute you want. There's also a lot of songs that have different kind of accepted cadences for the beats. So if there's a certain cadence that you find works well for your steps, you can always find a song that the beat kind of follows along with, okay? But the idea is here we're working on the rhythm part, we're working on step length, as well as freezing, because we're really working on getting that stride length more automatic. And again, sort of using those external things to help with overcoming what's happening in the basal ganglia. Okay. All right. Methods used for the second thing, which is strategies for addressing and preventing breakdown from occurring. Okay. So the biggest thing here is spending time on actually reflecting on what your triggers are. Okay. So this is so individualized, which makes it really hard for us as researchers sometimes to practice and to get freezes in people in a clinical setting, because what might make somebody freeze does not make that other person freeze, okay? So for you, it's really finding, and I know a lot of people say, oh, I think it's doorways, but that's not actually true for a lot of people, or that might not be your trigger, okay, consistently. The other thing to note is, how do we lower the cognitive load? Okay, so again, I was talking about oftentimes we think of freezing as you're doing too much at one time, where we've exceeded our load and our ability to kind of continue walking or shifting the motor programs in our brain from one thing to another. So, how do we globally work on bringing down our cognitive load while we're walking at the same time? And oftentimes, for a lot of people, that's examining your home. Okay, so if you have a situation where the TV's on, a spouse is talking, you have three things in one hand, and you're thinking about, oh, that alarm is going off, I need to go get to it. That is a lot of cognitive load, okay? Probably too much past our threshold. So thinking about how can we simplify everything, okay? The other thing is having a shared response. I call this a window of opportunity with my patients. And what that is oftentimes talking to people with Parkinson's, you know that you are in a freeze or you feel a freeze coming, you know you're stuck. So you might be here and you're like, oh, my feet are down, I can't step. And there's a huge connection in the basal ganglia, the part that's affected by Parkinson's, to the limbic system, which is a part of our brain that controls emotion and things like that. Because of that connection, we actually see when you're stressed, when you're anxious, when you're in a freeze and your system goes up and goes, this is really bad, I'm going to fall soon, and I'm panicking. That actually makes the freeze worse, okay? Because of that connection to the limbic system. So in those moments, I call them again a window of opportunity, where you sort of are at a decision point of, I'm in a freeze, my feet feel glued. If I make this worse right now and I'm stressed and I'm anxious and I'm thinking about, oh, I'm going to fall and this is going to be terrible and this is like last week and, I'm probably going to fall. Okay. And I'm probably going to get stuck. But if you can pause when you feel that happening, or even share with the spouse and family a cue such as big step, big step, big step, or march, or big arms, whatever your cue is that you and your family have found that's really helpful, we're not panicking. We just think about, I literally will tell them, just breathe and big step. And then we've brought our system down. We're not making it worse. We can have somebody, a family member or something, give that shared cue that we know in a calm way. And then we just bring ourselves down and we take the big step. And for whatever reason, that bringing the limbic system down and also having that cue is enough usually to sort of jolt that motor program, shake it off, or whatever it needs to. It's frozen and we need to kind of forcibly move it on to say, this is what we're doing right now. That's usually enough to kind of get us out of that freeze, because now we've sort of forcibly shift into a different motor program. I know that might feel a little abstract, but this tends to be really effective for people. So again, I'd encourage you with your families to just think about, bring it down and big step, or bring it down, whatever it may be. Okay, the other thing too, there's some sensory tricks here. I just talked about some, such as marching, arm swing. You might actually, if there's a particular freeze spot in your house, sometimes I encourage people to put a picture directly at the end of the hall from it if it's in a hall, or perhaps put a piece of tape kind of on the floor as you go through it, maybe, every couple feet. And then just as you walk through, look for the tape. Just look for the tape. Don't worry about anything else. Just look for the next piece of tape. Things like that. Okay. And I'm saying some of these as ideas. This does not mean that that will be your strategy for effective kind of overcoming of freezing, but they're ideas of things to try. Okay. The other thing is, like I was saying before, decreasing global arousal and stress because of that limbic system link. So thinking about how can you de-stress, which I say this and in my head, I'm thinking, I've got a meeting later I need to prep for. I'm teaching, like life is busy and I'm 100% not somebody that's going to say, oh, I just sit and meditate all day and this is so easy. I don't. But really, if we can work on bringing our global sort of stress and anxiety down, we often tend to see much related benefit in our freezing incidents and things like that. So oftentimes, I think I'll show some in the next slide, but there's some ideas for interventions such as meditation, progressive relaxation, where you're actually laying in bed in the morning when you get up and you're just progressively contracting and relaxing every part kind of systematically through your body. Getting really good quality sleep is a big one, and unfortunately, sleep is often an issue in Parkinson's. So if sleep is an issue for you, really figuring out sort of how that gets better. And then CBT, or cognitive behavioral therapy. This is actually a very evidence-based intervention as well, because oftentimes what we find is understandably people that have had a lot of issues with freezing, it becomes sort of this own entity where we think about it a lot. We're really afraid of it. Every time that we feel like it might happen, we're very stressed and we panic. And it's hard sometimes to get out of the loop. I'm saying to you, just think about this, but that might be really hard for people. So, if that is you, sometimes going to, a psychologist or something like that, they can actually give you strategies that maybe a physical therapy couldn't, for helping you sort of get out of that loop and then coming to PT to work on sort of all the other pieces to that. Okay. This might not be everyone. Again, this is just sort of general ideas I talk about with patients. The other thing is safe falling and fall recovery. Obviously, at the end of the day, I'm not going to tell you we're never going to freeze and we're never going to fall. Okay. Like that I couldn't guarantee that. And I would never say that because unfortunately these things do happen. But being able to know how to fall, as well as feeling confident that you can get off the floor safely if you needed to, tend to be very big confidence builders for people in terms of this whole kind of cycle. Okay. So that's something obviously not to practice at home alone or even practice usually at home altogether, but make a really nice opportunity for things to work on in physical therapy. Okay, and then the last thing is a symptom log. So whether it's your neurologist you're taking it to or your physical therapist, having some way to be tracking when you're most likely to freeze, what you're doing when you're freezing. It doesn't have to always be right away where you might have frozen and then you're like, I need to write this down. And, but just as sort of general, maybe it's at the end of the day when you're reflecting on how you felt that day and when you froze and what were the challenges and things like that. That really helps your medical team be able to look at, is your medication working? Are you, dosed appropriately? Are your DBS parameters maybe where they should be? What can your physical therapy, sessions focus on to give you the maximal benefit in these areas? Okay, all good things that really maximize your benefit. And intervention examples here. Again, those sensory tricks, sometimes it's motor imagery. So me thinking about every time I walk through that door, I'm walking through it. I'm not freezing. And I'm just laying in bed picturing that at night, maybe 10 or 12 times. Other things, counting. Some patients have an easy time with, so counting like their steps as they go through triggers. And then just identifying sort of those triggers to then have strategies for overcoming them. The other thing for decreasing kind of that global arousal, I often encourage patients to get you don't need a meditation app, like Calm is one. You can also just type in on YouTube, meditation, and then you can sort of go off on a rabbit hole of if you like sort of a particular person, if you want nature sounds to it, things like that. It's all free. But really, the other thing too, get outside, get into nature, try to eliminate stressors, all those things that we have a lot of actually very, very solid evidence, just like exercise, that tend to bring down our stress levels, are really, really important to be doing wherever possible. And then the other thing are ideas for symptom logs. So Strive PD is a very novel sort of program that's come out that allows you to do this. It uses the Apple Watch if there are any Apple users, but it can be as simple as pen and paper. It doesn't need to be fancy. It can be whatever amount of digital you want it to be. And again, just for communication with your provider. All right, and then the last thing, I think this is probably the part that maybe the group is most familiar with, working with Lisa and PD Connect, but just we need to, again, improve our functional capacity to be able to do all the things that I'm describing as well, okay? So we know for building aerobic kind of endurance, we want high intensity as much as possible, and there's some heart rate ranges here, okay, that we're trying to get. And then resistance training. So thinking about if I'm at a gym or if I'm at home, when do I use machines versus free weights? Okay. And oftentimes that trade-off is machine weights put us in a stable position. So really, when we're thinking about working on pure strength or pure power, okay, that strength with a short kind of burst to it, a fast quality, machines are often really good at that because we don't have to worry about keeping our balance at the same time. We're sitting on the machine or we're on the machine is stable. However, free weights or TRX sort of body weight supported things, maybe we're putting less weight on if that's safe for us, but that allows us often to work on our balance at the same time. Okay, so there's usually sort of a place for both of these in interventions, but it's important to sort of think about where we're, what we're working on and what the goal is. And the other thing on here is periodization, which is if anyone's been involved in a lot of weight training, the idea is we're giving you resistance exercise with a goal. So we're not just saying lift as much as you can for as long as you can and do it somewhat often. Okay, we want to be as specific as possible in what we're doing. So if we're trying to work on power, let's say, if I want to get really good at being able to generate force when I take a step, so that reactive balance when the munibus stops. Okay, I need to put a lot of load on, but have it be fast. So I'm not doing very many repetitions, which is kind of the complete opposite of what we're going to do if we're training something like endurance. Maybe my trunk muscles, which are on all the time for balance. Okay, I'm going to try to program that intervention for you to get those stronger with a lot of different parameters to it than power. Okay. All right, and here's just some examples here. Intervention. So PD Connect classes, awesome salient intervention. Probably a lot more fun than doing other things. On the weekends, though, thinking about, can you go stand up paddleboarding? Okay, and then here's this example of, to go back to that previous point of, if we're strength training, can we do rows using a TRX trainer where we're not loading as much, but we're working on our balance, versus using a machine for a row that's going to stabilize us and maybe we're loading more weight on. Okay, and there's a case for both. It just depends on what our goal is and what we want to work on. Okay, there's lots of others, but I think I'm kind of preaching to the choir for this part a little bit. Okay, and then other promising interventions. I did promise to make this non-totally PT exclusive. So there is a lot of promising research out there. So some of this is on deep brain stimulation. It's thought that perhaps, and this is very, very early, jury is still out, but that implanting of the globus pallidus internus, which is one area of the basal ganglia, may be more effective than the subthalamic nucleus. Okay, and again, the GPI target has been only being implanted a lot fewer years over time than the STN. It's a newer target. So we don't have as good of longitudinal data to support that yet, but so far it seems like that might be a better target for postural instability type symptoms, as well as treatment of your typical symptoms like tremor and bradykinesia and things like that. Other things, non-invasive neuromodulation. So, other than deep brain stimulation, things like using a magnetic coil on the top of the skull, basically, so no surgical intervention, to stimulate those areas of the brain, vagus nerve stimulation. This is TDCS in the middle here. These might be all things you've heard about or read about online, but they're all just different ways of stimulating the brain that are these two on the left side here would be more of your non-invasive options compared to DBS. And then there's a lot of wearables. So, is this pair of teal socks here? They're actually vibrating socks. There's a lot of watches you can wear and anklets you can wear that deliver stimulation. There's inserts, there's shoes. But it's the idea that are we able to kind of learn one's normal motor pattern? So your normal walking. And then if we start to feel that you're not doing that normal walking, we feel a freeze, we can deliver some stimulation to that body part, to your feet, to your ankles, whatever, to try and disrupt that motor pattern. Okay, similar to what we were suggesting for that cue, that window of opportunity, big step, this is almost doing the same from your learned movement patterns. Okay, and there's a ton of research coming out on this. If you want to be part of a clinical trial, I would say the wearables, think about any body part and any thing that you could potentially wear, and there's somebody doing a study for it somewhere for freezing of gait. Okay. And then just to briefly touch on what's beyond this. Okay. So one of the things that I want to point out is I often hear from patients, all we care about is freezing of gait. Why is nobody studying freezing of gait? And I just want to kind of shout, I guess, from the rooftops that lots of people are trying to study freezing of gait. And a lot of people, it's something that we know patients want and that we know it's significant in its symptom. Oftentimes I start these talks and I talk about what freezing is, and I talk about sort of the effects it has on quality of life and our autonomy and our ability to go everywhere. And I didn't start with that because I know a lot of you have lived experience. I don't need to tell you the effects that symptom has on your day to day. Okay. But oftentimes why it's so hard for us to study as researchers and so hard for us to treat as clinicians is, it's not a big number oftentimes. So we can't predictably say, have you come for an hour-long visit and say, you're going to freeze 100 times. Okay. That's probably not going to happen because, again, there's that limbic system link. And we oftentimes, it's been in the literature that the way that you walk in clinic and in a research lab is not how you walk in your house and in the community. And oftentimes as researchers, what we see in clinic is you on your best behavior, so to speak. So you with perfect walking, and there's this element of performance to it. And it's very hard for us as researchers to get a lot of freezes. And it's also hard for us to study if we're thinking about, how many freezes we need to be able to ascertain details from. That's pretty hard for us to get consistently. The other thing to note too is thinking about how we define the symptom of freezing. What if somebody is festinating, meaning they're taking those small steps instead of a freeze? We don't yet know that the festination has a different sort of part in the brain and how it's controlled than a freeze, right? Maybe there's two completely different things going on there that have different sort of underlying issues in those circuits. And we can't just lump them all together and say, this is all freezing, everything that's happening, we're just going to treat as one. Okay. So there's a lot of nuance, okay, is what I'm trying to say. Then the other thing is we can't just measure this with a clinical test. We can't just say, walk and we'll see how fast you walk. Okay. With freezing, we really have to measure this with sensors, with body worn devices. Okay. Which means you're in a research lab and you're wearing some sensors so that we can definitively say, this is what your body's doing at this given time. Okay. So the other thing too is data suggests interventions on freezing, whether we're looking at a device, DBS, PT, even to some degree, although less variability there, that they produce highly variable effects or benefit in people. So what works for one person may not work for this other person. And the reason for that is lots of times Parkinson's is a very sort of variable condition. So maybe somebody has had PD for 20 years and somebody's had it for 4. They might respond very differently to what we're trying to do. Oftentimes we know that symptoms sort of change in how responsive they are to levodopa, depending on how long somebody's had Parkinson's. Okay, so there's a lot of variation. And, if I'm running a clinical trial and I need 20 people, it's hard to know, okay, are these 20 people coming in all of around the same symptom severity, duration of their symptoms, primary motor symptom, they all freeze around the same time or trigger. It's very hard to account for all of that. I do want to just point out these two figures. The top one is a turns and barriers course, a very commonly used research kind of thing to get people to freeze. As you can imagine, it doesn't look super fun. So that's something that we're up against too, is how do we make these ways to get people to freeze kind of more fun, more naturalistic, things like that. And then this figure is a paper by the lab that I work on, one of the postdocs, Ken Louie, and he's basically just showing the way that the brain is changing as it relates to individual steps or stages of the gait cycle of how we walk, whether my foot's on the ground, whether it's in the air. And all that's trying to show is that, we can't just look at somebody saying, just walk, that'll give us the data that we need. But there's a lot of proof of the brain actually kind of changing through different parts of our walking, where we again need to study it bit by bit, not just do a test and see, did you freeze or not? That's not going to give us enough data to develop effective interventions. Okay. I'm just about at the end. I'll just put a plug in for sort of the research that my lab and a few others are doing, which is we know that Parkinson's affects sort of these circuits, like I showed you that complicated diagram before. And so technology recently made by Medtronic has allowed us to record here with special DBS electrodes. So we can actually record from regions in the brain, from in the basal ganglia, while people are doing all these things that we're talking about: freezing, walking, starting to walk, all those things, balancing. And what we do is we combine this brain data that we get with biomechanical data during postural tasks, freezing, things like that. And then we can start to associate sort of what somebody's symptoms are, okay, so that freeze, with their brain data and their body-worn sensor data showing everything their body is doing, okay? And that really is what we're finding we need to be able to do to know sort of each part in this of what's happening in the body, what's happening at the same time in the brain, and then how does that differ from maybe a healthy control to begin to try to formulate therapies that treat that, okay? And the goal is with adaptive deep brain stimulation sort of programming for people, but I'm not really going to go into that too much more. All right, this is my last slide. There's lots of ongoing research as promised, so less invasive work. Again, all those devices I was talking about earlier. So attempting to kind of give some external signal to break up or prevent a freeze, lots of sensors. Combine DBS and PT. So this is an avenue that I'm beginning to venture into, which is, how do we sort of dose these two interventions together to get maximal benefit and potentially long-term retention or carryover of benefit, as well as doing a lot of remote symptom monitoring to better understand sort of how these symptoms are occurring and when they're occurring across lots of people with different patient presentations, so that we can hopefully start to be able to develop interventions that aren't just like an N of one. Okay. The Bay Area is a hot commodity for research intervention in this area, I have to say. If you're living in the Bay Area, you are amongst lots of firms of very smart people looking at these kinds of questions. So we did partner with a startup called Skip that's improving or really making this lightweight wearable exoskeleton, improving gait and looking at freezing of gait in people with Parkinson's disease. So if you are interested at all in being part of this study, you can reach out to Jacob Marks. His email's here. And this is an ongoing partnership between the lab that I work in, which is under Dr. Doris Wong, who's a neurosurgeon at UCSF, as well as Skip, which is a startup. All right, so I have a lot of just kind of accessory slides of community resources and things like that, but I think it's probably a good time to start taking some questions.
Wow. Thank you so much, Dr. Bath. If you want to exit out of your slide, and then we can.
I have a question.
We do have a lot of questions, and let's put as many as we can in the chat, and then we'll have some people unmute as needed. But
Hi, I have a question. Can I do it without typing?
go ahead.
Oh, hi, thank you. Congratulations your PhD. A big question for me is I've been noticing the dopa wears off, and then I'll have to sit for a few minutes, take the pill, wait 20 minutes, everything's come back into action, I can move around like normal. But it's basically the medication is depleting. Any thoughts?
I apologize if I missed some of what you said, but you said you have to wait a little bit until the medication makes you feel on.
Right.
Is that true?
Yes, that's true for me.
Okay.
Yes.
Yeah, very, very common.
I have the
Are
same
you
issue.
asking why, or what if there an option for making that better, or?
Well, I probably don't know. I don't really care too much about the scientific why. I just want to find out what can I do to make myself feel normal, like I'm on the medication, without having to take all these pills. That's my question. I don't know if there's a good answer for that.
Yeah, I would say that would be a conversation with your neurologist to see if there's something else you can add. I know you said you didn't want the meds, but sometimes they can give you something that kind of keeps your on periods longer, so you're not experiencing such sort of really pronounced on time and off time, and shortening sort of that progression. I without knowing too much more too, it might be a conversation with your neurologist where, potentially you start thinking about things like DBS, things like that, but certainly it would be a conversation that would probably be more on the medical management side than the like PT, or managing that with maybe more of the lifestyle type modifications, unfortunately.
I did talk to the DBS team at UCSF, and because I don't have tremors, they said that the DBS may not be a good option.
Yeah. Should I start taking more questions from the chat?
Yes,
Yeah,
that would
just
be
working
great.
through.
Thank you.
Okay, so relationship between freezing and festinations post DBS. This is tricky because oftentimes, like I was showing, they sort of run together. And so it's like whether we're calling something freezing or we're calling it a festination, it's this idea that whether it's a complete stoppage of walking or it's sort of a lot of small steps going into either freeze or not, they oftentimes are thought to be kind of running together and treated together. So I would say for festination, everything that I said very much applies. I would just really think about, a lot of times as people start to festinate, their trunk goes forward, like I said, where they're taking these really small steps, but they are not moving their feet. Their feet are fixed and their trunk still is leaning forward. And the idea for doing that is because they want to try to make themselves go forward by shifting their mass forward to make it easier to get their foot up. But what happens is people actually sometimes will fall forward because now they've leaned forward and their feet are still where they started. So same kind of thing, except I think the retraining there would be, if you're festinating, calm down, have the cue, but try not to be leaning forward. If you're festinating, let yourself festinate, calm yourself down, think about that window of opportunity, but then don't let yourself continue to lean forward. That would be sort of, whether it's a mirror or something, teaching you to kind of unpair those two things happening. Question: when I don't have freezing of gait in the middle of the night and early morning, very common. Yeah, when I go to a public place, I have freezing of gait. I've learned many of the tricks. Okay, you've gotten all the secrets. I have no trouble walking up and down the stairs. What can I do about my freezing of gait? So I would say a few things. This might be an instance where I don't know if you use sort of some assistive device, whether it's a cane, whether it's a trekking pole, whether it's a walker, depending on how severe your symptoms are. This might be a really nice opportunity because this makes things oftentimes a lot easier for us. Again, we're thinking about bringing down overload, right? So if you think about at night, if you think about at home, much quieter of that, where we're at, of all the things we're having to process, than when we're out and about in a public place where there's a lot of things going around that we have to pay attention to. So oftentimes I would say in physical therapy, we could think about practicing. So it would be having you do a lot of things at home or in clinic where we're making you dual task and we're making you do things with walking in a safe manner that we can kind of challenge you and get you used to having to do the walking and prevent freezing in a way where you're around those things, but in a quieter sort of environment or more controlled environment or a safer environment with a PT next to you to guard you. But that would sort of be a training component. And then we would also probably, if that still didn't work or you still needed benefit, thinking about some cane or something or a walker if symptoms are more severe. Because oftentimes too, going back to public places, if we're really, really fatigued and we get tired, maybe I just walked across the airport and now I'm freezing while I'm, thinking about boarding the plane. That to me sounds like a fatigue issue. So maybe we just take the wheelchair to the gate so that we know that we're in a better place to sort of not freeze on the plane.
Right.
Things like that.
I've tried all those devices and I have all and
Yeah.
but your talk was fantastic in terms of focusing my attention on things I can work with. So thank you.
Yeah, you're welcome. How does this relate to bicycling? So interestingly enough, yeah, great question. So there's studies that have been done showing freezing, people that freeze, and then how do they cycle? Do they still freeze or not? Yes, they do. But I would say we oftentimes will use something that's like biking and things like that, or a rowing machine, things like that, that actually you can get into a nice cadence on. So similar to what I was saying with the treadmill is kind of getting into that more automatic motion. So a bike will actually kind of be nice because you're sort of, if your feet are in the pedals, you're going to keep going sort of until you get off. And so in some ways, we can actually sort of work on sort of training that rhythmicity with gait and things like that. For some people, I would say they don't see a lot of carryover with biking to walking, that those two tests are not, we've not made that connection for carryover. But sometimes, that's actually a really great intervention for people. So great question. Fascination include walking backwards or retropulsion. Interested in any findings on postural instability, freezing occurring after DBS? I would say so. Fascination, walking backwards tends to be a really hard task in people with Parkinson's in general. To the best of my knowledge, yes, we would probably consider that the same if people were having sort of those short steps when they tried to walk backwards. Retropulsion,
I'm just
yeah.
going to chime in here. This is Liza. It's actually, I lose my balance and I fall backwards sort of. So then I have to, so I just find that like that kind of like backwards thrust is something I've just been struggling with often, in the kitchen. I'll sort of like want to turn, but I find up falling backwards. And the only way I can stop is by crashing into the counter because I just keep on going.
Yeah, so you're very spot on that this is postural instability. So what you just described is exactly postural instability. So, I mean, for you, I would almost suggest like, yes, that symptom is very common with Parkinson's, first of all, to normalize retropulsion, as you called it, falling backwards. It sounds like, honestly, a lot of PT intervention generally on reactive stepping, knowing where our trunk is in space, because oftentimes you might think you're probably upright, but you might be back here in a lot of what you're doing. And so learning this is actually where we need to be 100% of the time, and how do we find that balance again? And there's a lot of really good evidence-based PT intervention for that, as well as it sounds like for some dynamic stepping responses for if I feel myself start to go back, how do I catch my balance in the right scaling to prevent a fall?
Yeah, thank you. I've actually found that sometimes wearing like a wedge heel is helpful. I tend to fall backwards more when I'm on flat feet because I wear bare feet in the house. And so when I have like a clog or something with a little bit of a lift, I feel more comfortable because I'm not feeling like I'm back on my heels, if that makes sense. It's strange.
That's your external cue, right?
Yeah.
Your wedge is that external cue, just like we were talking about. Yeah, very, very evidence-based of you.
Yeah, it makes me feel secure, sort of like my hiking poles you're talking about. I don't use them a lot, but I feel it's like a safety blanket when I go out. I feel like I've got like a sort of suit of armor because I can use them to dig in and get that opposition of my arms and my legs. Thanks.
Nice. Please review, clarify, leave it open, DBS coordination, how to manage symptoms without DBS. So oftentimes, so the first point I think about leave it open DBS is if somebody does get DBS, and I should say too, there's a lot of research here that I didn't talk about on when deciding to make the decision for DBS, making sure symptoms are medication responsive. okay, levodopa responsive, that's when we know we're going to have the best outcomes with DBS. So there's a whole conversation on DBS selection and criteria, which I know of, but I don't go into a lot because that's not my education or training. I'm not sitting in those meetings. But how to manage symptoms and clarifying the two. So oftentimes with postural responses, so I was saying for like our static balance where I'm just standing tall, like the question about retropulsion, where I'm not leaning backwards if I'm in my kitchen standing, I'm just right up and down. Or even some of our responses around like how we start to walk and our weight shift when we start to walk. Oftentimes we've seen levodopa can either make those much better for some aspects, not change them, or make them worse. Okay. And so oftentimes if we're doing a levodopa plus DBS, in the cases where levodopa has made that worse, we often see sort of the recovery of DBS on that thing. Okay. So that's sort of the trade-off or the coordination between the two. How to manage symptoms without DBS. Hopefully that was a lot of the talk around, we would hit PT early and often, we would do exercise, lifestyle modification, thinking about our triggers, managing them, bringing down the cognitive load, all those things. Does diet fit in? So it's actually interesting. I just talked to the second year PT students and we had a whole conversation about this. And I feel confident in saying right now, there's nothing that's conclusive on diet. However, there is some somewhat anecdotal and some studies, places online that you can find saying Mediterranean diet is better for overall symptoms of Parkinson's, as well as kind of veggies over red meat, which I think is probably the stuff that we hear for almost everything. Whole foods over processed foods, all of those sorts of things, that there is actually some evidence here for benefit on the motor side of PD as well. I use a regular flashlight, haven't tried laser. Yeah, if a flashlight works, certainly. The other thing too, which I know was not the point Joanne made, but just to also say lighting is often a great strategy for improving freezing around your house if you're having issues with that. Shadows, corners, things like that can often be very common triggers to people.
Great.
I listen to books while I'm walking.
Thank
Sorry,
you.
do you want? Yeah, I'm just
Thank you,
getting through.
Dr.
I'm
Beth.
happy to
be
stop.
here all
We
day.
could be here all day.
Yeah.
We did want to say thank you so
Okay.
much. We want to be respectful of your time as well. Thank you. Wonderful talk. Great information. Still a lot of questions. If you have more questions, please send us an email. We'll send them over. Also, a lot of people asking if they can watch this video again. Absolutely. Couple of ways to do that. Go to our website, pd-connect.org, and sign up for our newsletter that's sent out every week. And it's got a lot of great information that Lisa puts in there. But you could also just watch this video and any of our other guest speakers and exercise videos if you go to our YouTube channel, which is listed there in the chat. But if you just go to YouTube and type in PD Connect Wellness, it'll pop up. You can't miss us. It's a lot of orange and a lot.
I'm not wearing orange today.
You're not wearing orange today,
Oh
but
my
there's an
gosh.
orange wall behind us.
This is
Anyway,
true.
thank you so much for your
just the
time.
comments,
Yeah.
talk about cognitive load. Folks, this was a very highly subscribed. A lot of people registered for today's talk on freezing of gait because it is so important. And a lot of people are either going through it or have seen people and they want to know, what can I do now? How can I fix it? I'm having such trouble. So there were a lot of things in today's lecture that can help you right now. As Dr. Bath talked about, it's not maybe the levodopa or the DBS that's going to fix things. But if you take the time to watch this video again and understand some of these areas that you can intervene and help this process. And again, she talked about repetition, 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 and kind of going through things one by one so that you get this good neuroplasticity. The neuroplasticity is within you. It's not the DBS or the levodopa. It will be within you and you can access it at any time, and in any place. So we want those good patterns to establish in yourself.
Can you repeat that?
What, we were muted the whole time?
No.
So please take your time to go through this. There were really great things in this presentation. If you have questions, you can certainly email me, lisa@pd-connect.org, and I can figure out how to answer them or pass them on to Dr. Bath. And, we really just appreciate all of you being part of the community, and we want to encourage you all to exercise. If you don't know what PD Connect is, we are a nonprofit here in the San Francisco Bay Area, but
Virtually, wherever you are.
and we exercise every day, pretty much every day.
Yeah,
So
join us anytime.
all
Love to have
those
you.
things that we talked about, the set switching, the postural instability, the dual tasking, the cardio, the strength, the periodization,
Audio
all
motor
of those
entrainment.
audio motor entrainment,
Yeah.
all
the
of
things.
those things, we cover those in our classes.
Yeah.
So please consider joining us. Dr.
it.
Beth, any last comments or words of advice?
Best
You
of
got
luck to
meeting?
each of you. We just, hopefully, at least if nothing else, I 100% agree with what Lisa said, that there's a lot of emerging research here. So please stay tuned, have faith in it. We're all working really hard on your behalf. And we have a huge amount of, I think, obligation and appreciation for all of you for the bravery and the, persistence and the perseverance all of you show. So we're always mindful of it. Keep on.
Excellent.
Thank you so much.
right.
Have a great afternoon or evening or morning, wherever you are, and we will catch you all on the flip side. Thanks so much and enjoy.
Yeah, thanks
Bye,
very much.
everybody.